Hi, my name is Brittany and I'm a nurse practitioner student. Today I'll be performing a head-to-toe exam on you. Is that okay?
Yes.
Okay. So may I have your name, your age, and your ethnic background?
Nick Dussault, age 48, white Caucasian.
Okay. And if you feel uncomfortable at any time, go ahead and let me know, okay?
Okay.
Okay. So I'm gonna perform hand hygiene. And I'll begin by asking you a few simple questions, like to assess your orientation. So can you tell me where you are?
Las Vegas, Nevada.
What day it is?
Friday,
What day of the month it is?
12.
Okay, perfect. And so thank you. I'm going to describe a few of the things in your general survey. So Nick is a 48-year-old male, healthy, well-appearing and developed. He is alert and oriented ×3. He is pleasant and responsive to his questions. His skin color is uniform and consistent with his genetic background. He is dressed appropriately for the occasion. He is well groomed. His posture is upright. He is relaxed and in no apparent distress. So now I'm going to go ahead and begin by assessing the patient's head, face, and neck. So first I'm going to go ahead and palpate the patient's head and his scalp. So his hair is soft, evenly distributed, no alopecia noted. His scalp and skull is normal cephalic without atraumatic. There is no masses, lesions, or tenderness noted. His facial features are symmetric and his skin is smooth, warm, and it's consistent with his genetic background. So there is no redness or swelling noted along his face. Next, I'll go ahead and palpate. So I'm going to palpate the frontal sinuses, which are just above the eyebrows. Do you feel any pain here?
No.
Now I'm going to go ahead and palpate the maxillary sinuses, which are like right under his eyes. Do you feel any pain there?
No.
Okay. So patient says he doesn't feel any pain or tenderness in either sinuses. Now I'm going to go ahead and assess the patient's eyes. So I'm going to inspect the eyes and I'm going to look for symmetry and see if they're symmetric with the top of his ears, which they are. No ptosis is noted. That is where one eye is drooping. There is no drainage, crusting, lesions, or edema noted to the eyelids or the eyelashes. Now I'm going to go ahead and look inside his eyes by pulling down your bottom lid. Okay, and so there is it's non-esoteric, and the conjunctiva is pink, moist, and free of discharge. The cornea is clear without opacities, and the iris is flat. Okay. Next, I'm going to go ahead and check the patient's vision using the Snellen chart, which we have right here. So do you wear any glasses or contacts?
No.
Okay. So I'm going to go ahead and have you cover one eye with, I guess, this, and then this will be the Snellen chart. And I'm going to go ahead and have you, since it's a smaller one, 6 feet away, and you're going to read the smallest line possible with one eye, and then you're going to cover the left. So, okay, perfect. So cover the right. You're going to read this line.
LTFPH.
Okay, perfect. So vision is 20/20 in the left eye.
LTFPH.
And perfect. Vision is 20/20 in the right eye. Okay, so this assesses cranial nerve 2. This is an optic nerve, which is a sensory nerve, and so now we'll go ahead and move on. I will eventually do a fundoscopic exam, which is this tool where I'll be looking into your eye with a light, okay? Now I'm gonna check your pupils and assess your eye movement. So this assesses cranial nerve 3, 4, and 6, which are all motor nerves that mediate the eye muscles. So these help move the eyes and they assist with that extraocular eye movement. Okay, so cranial nerve 3 is ocular motor. So this mediates the pupil's ability to constrict. It also helps raise the eyelids and view through these levitator muscles and other muscles of the eye in the superior part of the eye. Okay, so medial and inferior rectus and the inferior oblique muscles as well. Okay, cranial nerve 4, which is trochlear. This is the inferior medial eye movement by superior oblique muscles. And then we have cranial nerve 6, which is the abducens. This is lateral eye movement by lateral rectus muscles. Okay. Now, so to check your pupils, I'm gonna go have you look straight at this vision chart, or I'll just plop it up over here, okay? You're gonna go ahead and look straight at that. And I'm gonna check for the pupil's response. Let's see, pen light, okay. So now I'm gonna shine a pen light into your eye. And the other one. Okay, now I'm gonna do the, so the pupil's ability to contract is intact. Now I'm gonna shine the light in the opposite pupil, and I'm gonna check the other pupil's response to the light stimulus. This is known as consensual response. So I'm gonna go ahead and shine here and make sure this one contracts. Okay, and same with this one. Perfect. So consensual response is intact. Now I'm gonna measure your pupils. Let's see. It's about a 4 on that side and 4 on this side. So pupils are about 4 millimeters in diameter. Both pupils are equal, round, and reactive to light. Now I'm gonna test for accommodation. So you're gonna go ahead and look at that red pole over there, and then you're gonna go ahead and look at me, or my pen, and then I'm gonna bring it to your nose, and this test for accommodation. So go ahead and look over there. Now look at my pen, and there we go. Okay, so accommodation is intact, so patient has pearla, so pupils are equal, round, and reactive to light and accommodation. Now I'm gonna assess the extraocular eye movements. So I'm gonna go ahead and have you look at my finger. Here. Okay. Perfect. So extraocular eye movements are smooth, full, and I don't see any nystagmus or paralysis of either eye is noted. So now I'm gonna go ahead and perform that fundoscopic exam with the light. You're gonna go ahead and look straight ahead at the wall or that red pole right there. And then I'm gonna go ahead and get close to your eye. So it may be a little bit uncomfortable as I get close, but then I'm gonna back up and then look at your eye again. Okay, so let's put this one. Okay, so with my right hand and right eye, I'm gonna look into your right eye, and then with my left eye, I'm gonna look into your left eye. So far away. Okay, and then I'll look to the other side. There we go. I'm gonna get close. Okay, so the red reflex is visible in both eyes. The optic disc is clear, round, creamy pink, margins are sharp. The cup disc ratio is less than half, no swelling is noted, and no increased cupping noted either. The retinal background is red-orange in color, the macula is slightly dark. The veins, arteries appear red, and the veins are slightly purple. The artery to vein ratio is about 2 to 3, with the veins being larger than the arteries. And there's no torosity of the vessels visible, and no exudates, hemorrhages are visible. Okay, so now we're gonna go ahead and assess the ears. So, ears are lined with the outer edges of your eyes. I'm gonna go ahead and touch the outside of your ear, and you're gonna tell me if you feel any pain or tenderness. Nope. Okay, so the auricle's non-tender. There's no redness or pain, swelling, discharge, or skin tags noted bilaterally. I'm going to assess the mastoid process, which is this bone right behind your ears. Do you have any pain?
No.
Okay. So patient says he feels no tenderness upon palpation, and I did not feel any masses noted bilaterally. Now we're going to do the tug test. This is where I'm going to pull back and up on your ear, and you're going to tell me if you feel any pain at all. Back and up.
No pain.
Okay, so no tenderness or pain noted, so no signs of otitis externa. Okay, now we're going to do the otoscopic exam. So I'm going to go ahead and look into your left ear first. And so I'll hold this. Maybe if I sit. And then I'm just going to. Okay?
See the other side.
I did. Okay. Okay, so the external auditory canal is pink. There is no cerium, no lesions or ulcerations or masses noted bilaterally. The tympanic membrane is pearly gray. There is no bulging, erythema, or effusions. In the left ear, I did see the cone of light at the 7 o'clock position, and in the right ear, I saw the cone of light at the 5 o'clock position. And the handle and short process of the malleus is visible bilaterally. Okay. Now we're going to go ahead and assess the nose. I can use this. I'm not going to put this in your nose. I'm just going to look. Up your nose. Okay, so I have to do that. I'm not gonna push hard or anything. Okay, so here I was looking at the mucosa. It is pink, moist, with no ulcerations. There was no bleeding or polyps noted. The inferior and midline turbinates are visible, and the superior turbinates cannot be visualized. So now I also assessed for septal deviation, which your septum is midline. Okay. So now we're gonna inspect the lips, mouth, and throat. This. Okay, so I'm gonna first look at your lips. Okay, so there's no ulcerations or lesions noted. Your lips are moist and pink, and there's no cracking or drying of the lips. Now I'm gonna inspect the inside of your mouth, so I'll use a tongue depressor. Okay, so go ahead and open your mouth and stick out your tongue. Okay. So buccal mucosa on both sides is pink and moist, free of any lesions or ulcerations. There is no swelling or any kind of nodules or masses noted. Now I'm going to go ahead and assess the patient's gums. Okay. So the gums are pink, moist, there's no bleeding or ulcerations, and there's no swelling. Now and the teeth were also aligned, good hygiene, no obvious dental caries noted either. The roof and floor of the mouth is pink and moist. There is no petechial lesions or ulcerations or discolorations. It was all uniform in color. The tongue I'm gonna go ahead and have you stick out your tongue and say ah. Okay, perfect. So the tongue is pink and moist. There were no fissures noted. There's no white patches or ulcerations. And then I'm gonna go ahead and have you I'm gonna look at your tonsils again. Okay, perfect. And so the tonsils are 2+ and they fill about 50% of your mouth, which is expected. So now I'm gonna go ahead and inspect the oropharynx and describe the Mallampati airway classification. So this is typically graded on a scale of 1 to 4, with 1 means a soft palate, the uvula and the pillars are completely visible. 2 is going to mean that it would be like less visible. 3 would be that the tonsils are larger, uvula is larger, and then 4 is going to be that only the hard palate is visible, and this usually is an estimate for about the amount of space available to intubate a patient, and it also puts a patient in a category for their risk for obstructive sleep apnea. So I'm gonna go ahead and have you open your mouth and say ah, and I'm gonna assess the uvula and the soft palate and see if it's visible. Okay, so I'm gonna grade this patient. Oropharynx is pink and moist and free of lesions and ulcerations. The amount of space I have, I'm gonna grade him at a level 1. Now I'm going to assess the patient's neck. So assessing the neck, the patient is symmetric, midline. I don't see any swelling or masses or discoloration. There is no obvious goiter in the throat, and there is no jugular vein distension noted. Now I'm going to palpate and inspect the trachea. So here, move up. The trachea is midline with no deviations. Now I'm going to inspect and palpate the thyroid. So I'll go ahead and stand behind you. Okay, so I'm gonna have you turn your head to the right, and actually I'm gonna put my hand on so it looks straight. I'm gonna put my hand on your thyroid, and then I'm gonna have you swallow. Okay, so there's no masses or nodules noted. I'm gonna have you go ahead and turn your head to the right and down, and then I'm gonna maybe not so down, maybe that's like that, okay. And then I'm gonna push the thyroid to the right, and then I'm gonna feel on the right side, and there are no masses noted, or nodules. And then I'm gonna have you turn your head to the left and kind of down, and I'm gonna just place the thyroid to the left, and I'm gonna feel on the left side as well. And so there's no masses, nodules, palpated on this side either. Okay, now I'm gonna go ahead and assess your lymph nodes. Okay, so we're gonna look for the pre-auricle, right here. Post-auricle, here. Occipital, here. Tonsillar, here. Submandibular. Can you see? Yeah? Yeah.
Mm-hmm.
Submandibular. Submental. Anterior superficial cervical. Deep cervical. Supraclavicular. And infraclavicular. So all lymph nodes are less than 1 centimeter in size. They are soft and they're mobile and non-tender. So if I was to have felt an abnormal lymph node, it would have been enlarged, so greater than 1 millimeter, it would have been hard, fixed, and tender. Okay. Oh, and then it could have also been matted where they're like stuck together a little bit. So now I'm going to assess the posterior chest. I'm going to have the patient sit upright, and his back is going to not be exposed. We're going to keep his shirt on for modesty purposes today. And I'm going to inspect the posterior thorax. It is symmetric in size and shape with no lesions, scars, nevi, masses, or striae visible. The skin color is appropriate for the patient's ethnic background. The spinous process is straight. The scapula are symmetric, and there is no unusual curvature or abnormalities noted. I don't see any kyphosis, lordosis, or scoliosis. The AP to transverse diameter ratio, so the anterior to posterior ratio, is approximately 1 to 2, and the patient is sitting relaxed and appears comfortable. Next, I'm going to go ahead and palpate. So I'm going to palpate the posterior chest bilaterally with the palms of my hands. Let me know if you feel any tenderness or pain while I assess for masses or abnormalities. Okay, so palpating. Do you have any pain? No? Okay, so no pain, tenderness, or masses noted. Now we're going to assess his respiratory expansion. So I'm going to locate T10, which is right under his scapula. I'll place my hands kind of together like this. I'll have him take a deep breath, and I'm going to watch the chest expand symmetrically, and then go back together. Okay, so take a deep breath. Okay, thoracic expansion is symmetric bilaterally. Now we're going to assess tactile phremitis. So I'm going to use the ulnar side of my hands and the bony palms. I'm going to compare bilaterally the vibrations when the patient says the word 99. So I'm going to start at the apices and go all the way down to the bases. So Logan, I'm going to have you say 99 every time you feel me touch you, okay? Okay, say 99.
99.
Again?
99.
Yeah.
99.
And
99.
yeah.
99.
Again?
99.
Okay. So tactile phremitis is present and equal bilaterally. There is no increase or decrease or absence in vibrations. Now we're going to percuss. So I'm going to have you lean slightly forward, and I'm going to percuss symmetrically along the apices all the way to the lung bases, so that I target every lung field. So when I percuss, I want to hear resonance, which is a hollow, low-pitched sound that is expected over healthy lung tissue. If you hear dullness, this could indicate a consolidation. It's like what you would hear over a solid organ or the liver. Hyperresonance is what you would hear if there was air trapping, so it would be something you would see in patients with emphysema or COPD. And then flatness would be if I was to percuss over a bone, so like the scapula. So I'm going to go ahead and percuss all the lung fields. Okay, so all lung fields are resonant throughout. Next, I'm going to assess for CVA tenderness. So I'm going to place my hand over the costovertebral angle, which is kind of like right here, and I'm going to tap with my other hand, but close like a fist. This, I'm assessing for costovertebral angle tenderness. Did you have any pain, Logan?
Nope.
So no pain or tenderness noted bilaterally. Okay, now I'm going to auscultate. So I'm going to listen with my stethoscope. you stay seated and kind of slightly lean forward. Every time you feel me place the stethoscope on your back, you're going to take a deep breath in and then exhale. And then if you become dizzy, just let me know and then we can pause. So you'll feel me auscultating in like 9 different lung fields. Okay. Okay. Take a deep breath. Okay, perfect. Okay, now I'm going to assess the bronchovesicular sounds, which are normally heard in the mid-scapular region, so right here. And then the vesicular sounds, which are heard in the peripheral lung fields, so that's going to be here. And then adventitious sounds would include wheezing, bronchi, and crackles. So I'll listen to the bronchiovesicular and then the vesicular. So just take a quick breath in for me and then out. And then take a deep breath in and out. Again. Again. And now the vesicular. Again. Vesicular again. And again. Okay. Perfect. Now we're going to assess agophony. And so you are going to say the word E every time you feel my stethoscope on your back. And I'm going to go in the same pattern from when I was listening to your lungs. So all you have to say is E. What I'm looking for is that I continuously hear the muffled E sound and that E does not turn into a muffled A sound, which could indicate fluid or consolidation in the lungs. Okay, so when you're ready, every time you feel the stethoscope, say E.
E, 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 E.
Okay, perfect. Lungs are clear to auscultation bilaterally. Now we're going to assess the anterior chest, so I'll have you turn around, Logan. Okay, and I am inspecting the front of the thorax. So the anterior chest wall is symmetric in size and shape. The anterior-posterior diameter is less than the transverse diameter, which is normal. Shoulders are symmetric. There are no lesions, scars, nevi, masses, or striae visible. There are no structural abnormalities noted. Things that I would be looking for is pectus incavatum and pectus carinatum, and this is where the chest bone is either coming out like a cone or tunneled in. So none of that is present. So the skin is smooth, dry, and appropriate for the patient's ethnicity. Respirations are quiet, rhythmic, and even. They are unlabored with no use of accessory muscles. Now we're going to go ahead and auscultate the front of your chest. Okay, so every time I place a stethoscope on your chest, you're going to go ahead and take a deep breath in and out, and then I'll move the stethoscope. Okay, perfect. And then now I'm going to assess the brachial breath sounds, which are normally heard over the trachea area, the bronchovesicular sounds, which are heard over the bronchi, which are the larger airways in the chest. And then I'm going to listen for the vesicular breath sounds, which are heard over the peripheral lung tissue. So this, and then if we were to hear adventitious lung sounds, this would include wheezing, bronchi, which could indicate obstructive lung disease such as COPD. So we'll go ahead and I'll do a quick listen over the bronchial breath sounds. Breathe in. Okay, now we're doing the bronchiovesicular. And then we'll just do the vesicular real quick. Okay. Perfect. So breath sounds are clear and equal bilaterally without adventitious lung sounds. Now we're going to assess the cardiovascular and peripheral vascular system. So we're going to go ahead and inspect the precordium, which is the heart. So I'm going to have the patient lay down in a 30, so I'll have you scoot up, like a 30-degree angle. Yeah, maybe scoot down a little more so your head is not all the way back like that. A little more. I'm sorry. Like this. There you go. Okay. So now I'm going to, the patient's shirt would normally be off at this point. So I'm going to inspect the chest and the precordium, and I don't see any visible pulsations, lifts, or heaves in the precordial area. Okay, now I'm going to assess for thrills, and I will use I'm going to assess for lifts and heaves using the pads of my fingers. So okay, so no hiffs or leaves noted. Now I'll assess for thrills using the ball of my hand, and I will again go over the precordial areas. And you can just breathe normal. Okay, so no thrills, leaves, or lifts or heaves noted, and there is no abnormal pulsations noted to the chest. Now I'm going to assess the apical impulse. So this will be at the second intercostal space, mid-clavicular line. No, fifth intercostal space at the mid-clavicular line, like right under the left nipple. This will be the point of maximal impulse. It is usually less than 2.5 centimeters in diameter, and it is usually brisk. If the apical impulse is laterally displaced, like further out, this can indicate an enlarged heart. Are you okay? Okay. An enlarged heart. And if the apical impulse is fast, like hyperkinetic, it could be due to young age, recent exercise, hyperthyroidism, anemia, aortic stenosis, or aortic regurgitation. Now I'm going to go ahead and listen to the heart, and with the diaphragm and the bell. So I'll go ahead and start with the diaphragm, and I'm going to auscultate all 5 areas. And you just breathe normal. Okay, now with the bell. Okay, perfect. So I was auscultating the aortic, which is at the second intercostal space along the sternal border on the right side. The pulmonic, which is at the second intercostal space left of the sternal border. Then the pulmonic, then the Erb's point, which is at the third intercostal space left of the sternal border. Then the tricuspid, fourth intercostal space left of the sternal border, and then mitral, the fifth intercostal space left of the sternal border at the mid-clavicular line. Okay. So I already listened with the diaphragm, and then I already listened with the bell. So we're all good there. Now I'm going to relay my findings, which the heart rate and rhythm are regular. S1 and S2 were present. There was no S3 or S4 or murmurs noted. There were no rubs or gallops noted as well. I would also auscultate the patient in a lateral left decubitus position, and then I would have him sit up and slightly lean forward. This brings the heart closer to the chest so I can hear better for like murmurs. But in order to preserve time for today, we're not going to go ahead and do that. We would just describe that that's what we would do next. Now we're going to assess for bruits. So the patient is going to remain on his back supine in the 30 degrees. You're okay? Okay. So I'm going to listen with the bell of my stethoscope. And you're going to take a deep breath in. When you take that deep breath, hold it. I'm going to listen, then exhale. And then I'll do the same thing. So first we're going to do carotid arteries. So take a deep breath in and hold. And out. Okay. Take a deep breath in and hold and out. Perfect. Okay. Now we're going to assess the abdominal aorta. The abdominal aorta is between the xiphoid process and the umbilicus, which is going to be right here. So take a deep breath in, hold, and then out. Take a deep breath in and hold. Hold it, holding it, and out. Okay? And then now we're going to assess the renal arteries. So this is going to be slightly below and lateral to the aorta. So deep breath in and hold. And out. Same thing on this side. Okay. And now we're going to assess the iliac arteries, which are below the umbilicus, but lateral. Again, hold, out. Hold and hold. Perfect. And then now we're going to assess the femoral arteries, which are going to be above his genes, which are right here. And then I'll just listen. Okay, other side. Okay, perfect. No bruits noted. Next, we're going to assess pulses. So pulses are graded on a scale of 0 to 3. 0 is absent, 1 is weak, 1 plus is weak, 2 plus is expected, and then expected and brisk, and then 3 plus is bounding. So we're going to assess the radial pulses first. So I'll take your hands. Radial. So these are regular and 2 plus bilaterally. Okay, next I will assess. So typically, actually, the radial pulses would be assessed for 60 seconds, but to save video for this time, we're just going to assess the regularity and amplitude. Okay, so next we're going to do the femoral pulses, which would be right here. And then those are 2 plus bilaterally. Next, we will palpate the popliteal pulses. kind of on that. And kind of bend your knees. And those are 2+ bilaterally. Next, we're going to do the posterior tibial pulses, which are behind the ankles. And those are 2+ bilaterally. And then we're going to do the dorsalis pedis. I'm just going to take your shoes off and actually do it. I won't take your socks off, but I'll try to feel the pulses. And those are 2+ bilaterally and equal. Okay, now we're going to assess the patient for edema, the skin temperature, the turgor, and cap refill. So I'm going to inspect and palpate his extremities for edema and temperature at this time. So I'll start with the upper. There's no edema noted. I'm squeezing the arms. Temperature feels normal. I'm going to assess the shins. There is no edema. Temperature is normal. So no edema present. Skin is warm throughout the upper and lower extremities. So if we were to see pitting edema, this is a soft swelling where when you press on the skin, it leaves a temporary indentation for about 1 to 2 seconds. This is graded on a scale of 1+ to 4+ based on the severity. Next, we have dependent edema, and this is a type of pitting edema that occurs in the lower extremities due to prolonged standing or sitting, and this is typically gravity related. And then we have anasarca. Anasarca is a severe generalized edema, which means all over the body. It involves the entire body and is commonly associated with kidney or liver failure. And so now you can go ahead and sit up towards the camera. We're going to assess skin turgor. So that is below the clavicle. You go ahead and pinch the skin. Okay. And skin turgor is elastic with no tenting. Then the cap refill, I'll assess the fingers. Okay, and then I will assess the patient's toes. Logan, do you want to take your socks off? I think it's going to make me anyway. And I just assess them real quick. And can you get them on? Perfect. Okay, cap refill is less than 2 seconds in the upper and lower extremities. Now we're going to inspect the abdomen. So you're going to have to lay supine again. I'll have you flat though. Okay. So I am inspecting the abdomen, and typically his shirt would be off, but like we said, modesty reasons, we'll leave it on. The abdomen is flat and symmetric, no lesions, scars, striae, herniations, or masses, or dilated veins are visible. There is no pulsation noted. If there was a pulsation visible over this ascending aorta or in the epigastric area, it would be a possible abdominal aortic aneurysm. This would mean we should not be palpating that area at all. Okay, now auscultation. We're going to listen to the abdominal sounds beginning in the right lower quadrant, and then we're going to proceed around the large intestine. So it'll be clockwise. So we're listening for bowel sounds, and we want to hear them in all 4 quadrants. So if they are hypoactive, they're going to be fewer than 5 per minute. If they're hyperactive, these are going to be more than 34 per minute. And then if I hear a growling sound, this is called borborygmy. Okay. I'm going to go ahead and listen to your bowel sounds. Right lower quadrant. And say we listen for a minute each quadrant, so we'll just speed it up. Next quadrant. Next quadrant. And the last quadrant. Okay, so vowel sounds are all normal active. Now we're going to assess for friction rub. We're going to auscultate the liver and the spleen. A friction rub is a grating sound that may be heard when the patient takes a breath in. It indicates a presence of inflammation on the peritoneal surface of the organs, possibly from a liver tumor, chlamydia, gonorrhea infections, recent liver biopsies, or splenic infections, or a splenic infarct. So when there's a friction rub heard over the liver, this could indicate hepatic carcinoma. And so I'm going to go ahead and listen to the liver and the spleen this time. Liver. Spleen. Okay, so there are no friction rubs heard upon auscultation. Now we're going to listen for a venous hum, and this is where we auscultate the liver and the epigastric and umbilicus region, so it's kind of like all right there. And we're going to listen for this venous hum. Okay, there's no venous hum noted. A venous hum is rare, but it is a soft systolic and diastolic hum that may be heard over the liver, epigastric, and umbilicus region. It can indicate an increased collateral circulation as well as hepatic cirrhosis. Now we're going to go ahead and percuss. So we're going to percuss all 4 quadrants of the abdomen. We want to hear tympany throughout, so let's go ahead and do that. Tympany is heard in all 4 quadrants. Now we're going to assess liver span. So this checks for hepatomegaly, which is enlargement of the liver. And so we're going to start percussing with the finger about at the 3rd intercostal space, midclavicular line here, and we'll go work our way down. And then we'll start from the bottom and work our way up once we hear a dull sound, and then we'll measure the 2, and then we can measure how big the liver is. So I'm going to percuss from here up until I hear the liver, which I'm going to put this penny where I heard it. I'm going to do it again. And I'm going to put this paper clip. Now we will measure. And it's about 6 centimeters, which is within the expected range of the 6 to 12 centimeter, 6 to 12 centimeters. Okay, now we're going to palpate. I'm going to do light palpation first. And I'm going to palpate all quadrants slightly. Tell me if you feel any pain while I do this. Did you feel any pain? No pain. Okay? So no tenderness, guarding masses, or rigidity noted. Now I'm going to do deep palpation. So this is 2 hands. Tell me if you feel any pain. Nothing? Okay, so no tenderness, guarding masses, or rigidity noted upon deep palpation as well. Now we're going to assess the liver and the spleen. So I'm going to hook my fingers underneath the costal margins while supporting the backside of your rib cage. And feel, there you go. Do you have any pain? Okay. Feeling the liver and the spleen, no pain. Okay. So we have no hepatomegaly or splenomegaly noted. Okay, now we're going to continue with some tests to assess for a possible appendicitis. So we're going to do the psoas sign. I'm going to have you lay straight. I'm going to place my hand on the top of your right thigh, and I'm going to have you raise your thigh against my hand. Okay, and back down. Did you feel any pain? No. Negative psoas sign. Okay, now I am going to do the obturator sign. So you're going to have your knee at a 90-degree angle, like this, like that, and I'm going to go ahead and bend and rotate your hip inward, like this. Do you feel any pain? That is a negative obturator sign. Now we're going to assess for rebound tenderness at the McBurney's point. So this is where I'm going to palpate the right lower quadrant and a little bit above, like between your belly button, right in the middle. I'm going to press down and release. Did you have any pain? That is a negative, or sharp discomfort. Okay, so that could indicate appendicitis if you did, but since you have no pain, that is negative rebound tenderness. Now I'm going to do the Rossving sign. So I'm going to press deeply in the left lower quadrant, quickly release the pressure. Did you feel pain on the right side?
No.
Okay, so that is going to be negative, negative sign. So no pain. That is a negative Rossving sign. Finally, I'm going to test for cholecystitis, which is the gallbladder. It's called a Murphy sign, just a Murphy sign. I'm going to put my fingers under the right rib cage, along with using the opposite hands to reach under the back and slightly support the rib cage on the side that's being palpated, and then take a deep breath. Did you have any pain? Okay, so that is going to be a negative Murray's sign. Okay, so next we're going to move on to the neurological exam. So I'm going to check your balance and coordination. I'll have you stand up over here. And you're going to just walk to me and then walk back. And then turn around and walk back. Okay. So the gait is smooth, steady, and you had natural arm swing. There was no steppage or gait. Now we're going to do the Romberg's test. So you're going to go ahead and close your eyes, and you're going to stand there for 1 minute. So say 1 minute has passed at this time. The patient wasn't swaying or moving. You can open your eyes. The negative Romberg's, he has a negative Romberg's test, which is what we expected. Now I'm going to go ahead and have you take a seat, which you could straddle, so that you're facing me. And I'm going to have you do the rapid alternating movement. So you're going to touch your thumb to all the fingers on the same hand, and then back, and then do the same with the other hand. Perfect, other hand. Perfect. Okay, so movements are smooth and accurate. Now I'm going to have you do the point-to-point test. So you're going to touch your finger to your nose, and then touch my finger, and then touch your nose. Then touch my finger, and then do that with the other side. So touch your nose, touch, and then now switch sides. So, yeah. Perfect. Okay, so both sides, movements are smooth, accurate, no tremors or fasciculations noted. Now we're going to go ahead and do the heel to shin test. So swing that foot over, and you're going to place your right heel, so all the way, right heel, or left heel on your right shin and move it down, and then your right heel on your left shin and move it down. Movement is smooth and controlled. Perfect. So now we're going to do the pronator drift. So I'm gonna go ahead and have you hold out your arms with your hands up, and you're gonna hold it for 10 seconds. So we'll say 10 seconds is up, and now I'm gonna have you do the same thing with your eyes closed. Okay, and we'll say that the 10 seconds is up and we have no pronator drift is noted. Now we're gonna do sensory function. So you're gonna tell me if you feel a sharp or dull sensation and I'll do upper and lower extremities here. Starting distal and working my way proximal. So I'm gonna test the feet, ankles, and legs moving distal to proximal. So I'll have you scoot, yeah. Yeah, actually we could do that, perfect. You're gonna not look and you're gonna tell me if it's sharp, like that, or dull, like that, okay? What is that?
Sharp, dull, sharp, dull, sharp, dull, sharp, dull, sharp, dull.
Perfect, okay. And now we're gonna do the same thing on the upper extremities. So put your hand and then keep your eyes closed.
Sharp, dull, dull, sharp, dull, sharp.
Okay, perfect. So sensation is intact on the upper and lower extremities. With both sharp and dull. Okay, now we're gonna do discriminative sensations. You're gonna go ahead and close your eyes or open your hands and tell me what I place in your hand. It is either going to be a paper clip or a coin. Okay, what did I place?
Coin, paper clip, coin.
Okay, perfect. So sternognosis is intact. Now you're going to keep your eyes closed and you're going to keep your hand open, and I'm going to draw a number using a pencil, and you're going to tell me what number that I draw.
5,
Okay? And then in the other hands.
3,
Perfect. So graphesthesia is intact. So discriminative sensation is intact bilaterally via sternognosis and graphesthesia. Okay, now we're going to do the meningeal sign. I'm going to go ahead and have you lay down flat again.
my back.
Yep, on your back. And I'm going to have you move your head to your chin, if you can do that. Perfect. Okay, did you feel any pain?
Yeah.
So it was smooth movement, no flexion of the hips or the knees. So that is a negative Budinsky's test. You're going to keep laying flat on the table. I'm going to have you raise your legs to a 90-degree angle. Do you have any? And then I'm going to extend them. Do you have any pain in your back? And your neck is not flexed, so I did not feel any resistance when trying to straighten the patient's leg. This is also a negative Koenig's test. So this concludes the exam. I'll help you up. Thank you for your assistance.